I would like to thank at the outset Mindray for giving me this opportunity to share our experience of using the MC80 digital morphology analyzer in our setup. And I will immediately delve into the presentation. So I bring you warm greetings from my institution, which is the BLK-Max Super Specialty Hospital, New Delhi, and the Institute of Laboratory Medicine. And this is the team with whom I work and with whose support and constant encouragement, we are able to do good job and good work. And fortunately, we've been able to standardize our system on the digital morphology platform as well. So what I have done is, as far as my disclosures are concerned, I do not have any significant disclosures except that I'm presenting this for Mindray on their platform. And important point which I wanted to make is that I have actually put it an outline of the presentation into following subtopics, where I've talked about the hematology testing scenario which is present globally. Journey of a complete blood count or a full blood count sample as it comes into any laboratory, and I'm sure most of us are aware of that. The manual peripheral blood smear, scanning, examination or review, whatever you may want to call it, and we'll see very interesting publication which has come up on this and talking about principles, processes and limitations of the manual blood smear examination. And then talking about artificial intelligence and automated peripheral blood scanning, smear, examination, review. Of course, the experience which we've had with our system here and the cases that we've seen, and of course, some summaries and take-home messages when I finish my talk. So if I would have asked a question to anyone, as a quiz and said, which is the most commonly ordered test globally? And I'm sure everybody would in unison say it's the complete blood count or the full blood count. And what we know is that more than 30% of the lab test requests are actually getting this particular test done, which is the complete blood counts. And not only do you do this test primarily for any patient for that matter who arrives in a setting of a medical care, you're also doing it for patients wherein you're trying to screen for any blood disorders or you're screening for any hemoparasites. And you're also looking at screening for infections, inflammations, anemias, and of course, the coagulation abnormalities. And in all of these cases, complete blood counts happen to be the most commonly advised test for any patient. Now, when we get a complete blood count examination in any of the laboratories, who are handling hematology today, we generally put that sample through an automation, and the automation is on a hematology analyzer, wherein generally we have these three characteristic principles. Either we have the electrical current which we're employing to identify and count the particles or the cells, or use the light scatter and the radio frequency. Now, these are the usual ones which are used by most of the people. And just to reiterate and re-emphasize on the fact that what happens to the sample the moment it reaches a CBC analyzer gets aspirated and gets divided into two parts. One for the RBC, wherein you have the RBC platelet channel. You look at the RBCs and the platelet parameters. And of course, you also get hemoglobin from the same channel. And of course, the RBC, if you're wanting to take it further to the reticulocyte channel as well. And then you have a WBC bath or a WBC channel where, depending upon the technology used, you identify various white blood cells, and then the entire information is taken across into a scatter plot, into a laser system or a flow cytometry system, from wherein the pulses which have come in from the electrical impedance-based system versus the flow-based system are integrated, and finally the entire information is given across in the form of a data plot or the digital information. Now, this is a classical electrical impedance which happens, and in this what we do generally is, as you can see, that these particles which are passing between the two electrodes, the positive and the negative electrodes, through a proper buffer and an aperture, which otherwise was called the Coulter principle. And in this, the mechanism is that you're using the non-conductive properties of blood cells when they are passing through the orifice to obstruct the passage of the current and causing impedance. And that's why the concept of impedance. And of course, we are counting RBCs and platelets, as I mentioned in my previous slide, together through the same channel, and they are separated by pulse heights, and therefore we are able to count them separately. And of course, we also ensure that there is hydrodynamic focusing to allow one particle to pass at a time. And this all is history. We all know it and do it on a regular basis. Now, what was the aim of having a cell counter? The aim of having a cell counter was that you wanted to reduce manual labor, primarily for the simple fact that if there is a laboratory handling, say, for instance, about 500 samples a day, you will not be in a position to review all 500 smears a day, because then you will need a lot of people handling this. And of course, your aim was to ensure that you reduce the work of reviewing as much as you could. But at the same time, what is the thing that worries you the most is to ensure that there are no misses in the cases. So you do not want a case miss, but you want to reduce manual labor and reduce the review rates. And that was the purpose why we wanted to have a cell counter in place at the outset. Let's look at the complete blood count, as a test, and how does the sample finally reach a result. This is what we need to look at. We got it from the analyzer, and as you can see, this traffic light basically deciding whether you're wanting to, release the results or not release the results, depending upon various flags which come up in these analyzers. And thus, if there is no flagging, or it's what's called the flag negative result, you would allow it to go to the reporting system. And if it is positive, you would obviously need a peripheral smear review, and then only you will report. And of course, if there is an error of any kind in the analyzer, again, you would like to do a peripheral smear review and finally report. So if you look at this particular graphic cartoon, which I have mentioned over here, peripheral smear review happens to be extremely central to the results, which are either positive or having any kind of errors from the analyzer. So what do you do after an automated complete blood count and a differential count has been produced? Obviously, we all verify the report, and verify the report only and only after the fact that we do not need to dilute the sample first, or repeat it with or without dilution or some other analyzer. Sometimes you would like to definitely look at a smear and then review the visual differential counts. And you might many a times want to actually look at the manual platelet counts and maybe even do follow-up tests, just as the way my predecessor was talking about doing NS1 antigen in a dengue case. So interestingly, when I was trying to prepare for this presentation, I realized, all of us have different terminologies and methodologies of looking at a peripheral blood film. And when we look at a peripheral blood film, there are people who actually scan the peripheral blood film, or there are others who say, no, I examine a peripheral blood film, and there are others who say we review a peripheral blood film. Nevertheless, whether you scan, you examine, or you review, in all the three cases, you're actually interested in looking at the morphological features which are available on the peripheral blood film for you to review. Now, what are the principles for a review of a peripheral blood film? The idea or the primary principle is you want to reduce the number of samples which you would actually review to the greatest possible extent. And obviously, in such circumstances, the number of samples which are processed in any analyzers today happen to be in hundreds per hour. And therefore, humans, even though they will be able to review all those smears, obviously it's the man who creates the machine, but we have our own limitations of looking at the smear. And of course, we also have a significantly higher labor costs across some regions in the globe. And also importantly, sometimes we may have false positive results from the analyzers, which can potentially increase your burden, but at the same time, you don't want to have a false negative because that can harm your patient. So obviously, when you're looking for review in general, you have to look at the pile load of the test, but at the same time, visualize the risks which you can potentially have for the patient. And of course, you need some smart people like me, who eventually will review the smear, manually when they're trying to do it on a microscope. So let's see what happens when you do a manual microscopy. When you do manual microscopy, you place the slide onto the microscope, and you keep, you need to have a microscope, and on the microscope, you place a peripheral smear, and then you review the peripheral smear. You look at various cells, whether it's the WBCs, the RBCs, and the platelets. And you also obviously have different types of counters. Some of them use electronic ones. Nowadays, people have started using the app on their phones and counting the cells. And all this is possible to be done. And you will be able to get your manual microscopy slide. So if you look at it, what are you getting? You're getting morphological information, both for RBCs, for the WBCs. And of course, you also look at the platelets. And you also would like to see whether there are any inclusions, any parasites, etc. All this is happening when you are sitting across on a microscope and reviewing a peripheral smear manually. Now, so what are the issues? Life was so good, we can just sit down and do the manual smear look and just give the results out, But remember, any and every manual smear review will involve time, will involve labor, And of course, there will be variability amongst individuals when they are trying to visualize the smears. So therefore, there might be one person who's an extreme expertise, the top of the expertise or the top of the line, and the other side, you might be having a novice in your system who may not be able to actually review the images or the pictures in such a way that he gives you the most correct information. And obviously, there are no historical images. Most of the times, I'm sure most of us, when we use smears in our laboratories, once we have gone through the smear review, we just drop it into a bin and let it go away. And obviously, no traceability, significant storage constraints, and sternus activity, because you have to keep on doing a manual labor. So therefore, practically speaking, for anyone to keep reviewing the smears all the time manually is always going to be relatively difficult. Now, when you look at the hematology workflow and the challenges that you have in the slide review, which I just mentioned, there are umpteen number of them. Of course, you have some places across the globe where you have senior technical staff, who will actually sit down and review the smears, and then if they find there's anything which is a problematic one, they will transfer it manually to the pathologists or the experts for review. And this review expertise, which is going across between technical staff, between the pathologists and the experts which are sitting at a distance, is always going to take significant amount of time for getting us the right results to the patient very quickly. So therefore, what happens when you do digital morphology and use artificial intelligence? When you use digital morphology and artificial intelligence, you will start having workflow efficiency, you will have a reduced turnaround time, and your diagnostic accuracy is obviously going to increase, because now you are involving the artificial intelligence to give you a hint towards a particular diagnosis. So therefore, when you look at image analysis, or you look at facilitated centralized services or archiving and the easy retrieval, you are able to get all the information which was required in your patient's case. So this is the typical digital morphological analysis which one is able to achieve after using an instrument like MC80 from Mindray, wherein we are actually able to look at the red blood cells. We're able to identify different white blood cells. For example, if you see here, you have the neutrophils, the lymphocytes, the monocytes, basophils, and eosinophils. And of course, you're able to pick up your platelets, and this kind of a picture is generally not usually seen on a smear very easily, whereas digital morphology platforms, it's been picked up more often. And of course, the parasites. So are we able to really look at all the digital images with respect to RBCs, WBCs, platelets, parasites, etc.? The answer to that is yes, the digital morphology analyzer is able to do that and give you a very good information. Mind you, if you look at the pictures at the top, you are also able to pick up certain specific cell types. For example, if you're looking at the normochromic cells in this case, you're able to quantify them as well pretty significantly. So why digitization? You can have partial automation of your smear review. We know that the human being is still involved at some point of time. Again, review of the time will be shorter. There'll be redistribution of time and effort for the complex cases. You can obviously redistribute your cases to the people within your system. And if you have the right pre-part of it, the pre-analytical part of it on the digitization, your image quality will be very remarkable. And obviously, there'll be reduced inter-observer variability. And of course, you can also use it for many other things like having better utilization of resources. There can be traceability. You can archive the images. And of course, we can have it as a teaching tool and competency assessment, which is so important today when we are talking about the accreditation purposes. Now, when you review a case, you will look at the scatter plot, you will look at the histograms which are available with you, and of course, then finally the morphology. And when you get all these kind of different cells, whether in WBCs, RBCs, etc., you are actually reporting in an ideal fashion a complete blood count. And that's where the important point of morphology starts coming in. And how do you actually decide whether you will make a slide or not make a slide? And for that, fortunately, we have very distinct guidelines which have come in from the International Council for Standardization in Hematology. And that's for, the analyzers part of it, where we're looking at how the analyzers will give us differential counts and other counts, and how we are eventually going to be using the slide review criteria for getting us the right slides to be made whenever we need them. So what does the digitization do? You have a slide maker, which is here in this case, and then on a slide maker, a smear is made very uniformly, and all the time it's made in a similar fashion. And then the entire thing gets into a stainer module and gets stained within the system, and then finally into the digital module, which gives you a digital image part of it. And therefore, this entire process gets driven by artificial intelligence and is compared to the library which is available within the system, giving you the information in terms of different differentials which are coming across to you as a potential. This is the analyzer which we have placed in our system here at BL Kapoor Hospital in Delhi. And when we installed it, what we were told is that in comparison to the competition, the depth of fusion technology is pretty significant. They are able to give us far better imaging, and this is what we thought we should be trying and analyzing whether we are able to do that in our center or not. And we looked at the claims with respect to having better resolution of the images also, which was also given across to us. Now, when you set up any instrument in your setup, there are challenges. Anything new which comes in, you need to get used to it, and the entire process needs to be set, standardized, and moved across. So when you have setting up challenges, what do you do in such circumstances? So as far as the digital morphology platforms are concerned, fortunately, there are certain literature which is available, which is called the ICSH, the Indian International Council for Standardization in Hematology recommendations, wherein they have talked about how the digital morphology analyzers need to be set up in hematology and eventually taken care of with respect to the morphological information which comes out from them. But just notice in this particular conclusion of the abstract, which they have very clearly mentioned, the pre-analytical, analytical, and post-analytical parameters need to be standardized appropriately. So if you do not have a standardization of the pre-analytics part of it, obviously you're going to get into a messy state. Now, this is what we saw while we were setting up. Obviously, we had challenges first to install the machine, then to get the right set of the computer across, then to make sure that the computer, which has the capability of handling the images of that high size capacity, and also to ensure that it doesn't it has a very good RAM. So if you look at it from the technological standpoint, all these computerization aspects become extremely important. But the most important thing happens is when you actually sit down, stain, and if your staining is not kind of good. So if you look at the images which I'm showing you, this is the image which we got in the first time when we were trying to set up the entire process, and obviously it took us some time to realize what we were doing, and slowly you can see the staining kind of started improving. And while we kept on doing this activity of making staining better and better, finally we were able to reach a stage where our staining became very crisp and was able to give us the information which we desired. So the first and the primary step when we set up this instrumentation in our laboratory, the biggest challenges which we had was primarily of setting it up. And in fact, to be honest, we're still in the process of kind of learning and moving through in the process. Now I'll show you some interesting case studies with various cell lines which we've been able to pick up from these analyzers in the past about a month or two that we've been having the instrument. So just to show you the first one, which is a very classical normocytic, normochromic red blood cells, and you can see the blood film which has been taken across from one of the patients. And what you can see, even in this, the analyzer itself from the RBC data which is coming up is very characteristically showing that there is nothing which has been kind of highlighted. And obviously you can also see that the image is very beautifully showing the typical normocytic normochromic red cells, and we are able to very distinctly see that they're having appropriate color and the kind of picture that we expect in a typical normal case, right? And another higher power view of the same. Now, let's look at the other aspect here. Obviously, what you're able to see in this particular case is you see the RBCs have highlighted the anisocytosis, macrocytosis, and hypochromia. And you can already try and see this happening onto the image as well. And when you put across, it on a relatively higher power, you're able to pick it up further. Just look at the picture, which is showing you all these hypochromic microcytes. And this is another information which you're able to pick up from these digital morphology analyzers, wherein you're able to get these typical hypochromic red cells, and they are actually giving you a relative percentages of hypochromic. So, for example, if you see this hypochromic red cells in this particular case, you have about 38% hypochromic red cells, you have 23% microcytes, and of course, you still have about 1% macrocytes. So this gives you a quantitation vis-a-vis from the smear, and this obviously becomes highly reproducible when you compare it with any manual methodology of handling the cases. Let's look at another case of hypochromia. And as you see in this particular case, the analyzer has very distinctly picked up hypochromic cells and told you that there are about 27% of them, 3 plus hypochromic cells. And therefore, when you look at this image over here, this is very prominently highlighted the hypochromic cells, and this is possible to be done on this analyzer, as you can see in this particular case. You can also appreciate the presence of an occasional target cell in this particular case. Coming to macrocytes, again, when you look at this analyzer, it's been able to pick up all my macrocytes. It's already letting me know that we have significant anisocytosis. There is some anisochromia. There is also hypochromic cells and polychromasia. And all this is pretty distinctly visible in this particular case when we are looking at the smear on the digital morphology platform. And we are also interestingly able to pick up the significant basophilic stippling which you see in some of the red blood cells. So this normally, when you sit across on a microscope and you would like to pick it up from manual microscopy standpoint, picking up such finer detail requires a lot of effort, time, and energy. Whereas when you sit down with the digital morphology platform, it has already picked up a lot of this information and given it across to you on the digital platform in front of you. Another case of macrocytosis from our center, where we had significant number of macrocytes. And if you look at it, they were all very distinctly highlighted by the digital morphology analyzer. And obviously, we got relative percentages as well. Looking at the target cells, as you can see, there is poikilocytosis, which it's picked up, and it's also very distinctly told us that there are target cells over here, and all of them have been highlighted in this image, which I'm showing you in front of your screen. Now, this was a very interesting case post-liver transplant, wherein we were the patient was put on tacrolimus, and I'm sure people who are dealing with transplants would realize that when you give drugs like tacrolimus, presence of fragmented red cells in the peripheral blood becomes very important. And even for the transplant per se, the presence of fragmented red cells become important in the peripheral blood because there is something called post-transplant thrombotic thrombocytopenic purpura. Now, I'm sure a lot of us, who are actually dealing with the information from the hematology analyzers would realize that whenever you have fragmented red cells, you have, the left side of the curve on the RBC histogram, which does not touch the baseline, and you're able to pick it up from there. But in this particular case, if you see, there was no highlighting of the fragmented red cells because it had touched the baseline in this particular case. So obviously, the histograms were not really useful to us. But when we looked at the picture which was coming from the digital morphology analyzer, because it got highlighted for the immature granulocytes, and therefore it went ahead and made a smear, and we got a leukoerythroblastic picture. We found these nucleated red blood cells on the digital morphology, and we also found a significant left shift. Along with that, we found the presence of fragmented red cells, which you can see in this case in these tiny incests. Interestingly, it also gives you percentage of the fragmented red cells, and that becomes extremely important in cases where we are dealing with post-transplant. Now, in this particular case, the patient had on day 0 presence of 7.8% fragmented cells. Now, when we went on to day 2, the number of fragmented cells, you can visually also see that the number of fragmented red cells have increased in this particular case, and they have risen to about 15.2%. And this was a case of post-transplant TTP. Generally, it's very difficult to treat such patients, but it's important for us to identify them. And therefore, having digital morphology platform actually gave us a very nice insight from 7.8% of fragmented red cells to 15.2%, telling us that, the patient was actually not doing well, he was deteriorating. Again, there was another case, this was a child in whom we were able to pick up the fragmented red cells on the hematology analyzer. You can appreciate these fragmented red cells, which are there in this image. You can also appreciate the presence of polychromatic RBCs. All these bluish colored RBCs are picked up very beautifully on the digital morphology platform. And this was a child of hemolytic uremic syndrome, and we were able to pick it up. There was another case wherein one of our clinical colleagues wanted to know whether there is presence of stomatocytes in this particular patient or not. And we actually looked at it, and you can see it's already highlighted it here that yes, there are presence of stomatocytes, and they were obviously very distinctly picked up, on delineating them further by using the software. So we were able to pick up, of course, this number of stomatocytes in this patient would not really matter because they were not in plenty, but at the same time, presence of stomatocytes was very obviously seen on the smear, and this was seen in the digital morphology platform very vividly. Another case, a child, who was coming with the classical picture of hemolysis as far as the clinical findings were concerned. And the hematology analyzer, the digital morphology analyzer, had taken it up for a smear review post the rules which it, kind of looked at. And we got a spherocytic flag, and obviously we could also see the presence of spherocytes in this picture. And of course, there is polychromasia, which you can see in the background, very distinctly telling you that we're dealing with a case of spherocytosis. Another case wherein we had presence of the teardrop cells, and if you see in this particular case, we have so many teardrop cells in the background, and all of them have been very distinctly highlighted. And you can see this was a case of Gaucher's disease, wherein the marrow there was a significant splenomegaly, and the peripheral blood film showed presence of numerous teardrop cells, which were very nicely and beautifully picked up by the digital morphology analyzer. Again, another case wherein there was a patient of liver disorder where we were able to pick up very distinctly and beautifully the presence of echinocytes and acanthocytes in such patients. And it was also very distinctly highlighted. There was presence of fragmented red cells as well in this particular case. And this was a case of subacute DIC in a patient in our center. Another case wherein very distinct rouleau formation is very obvious, which you can see in the smear. And again, it's been highlighted by the instrument very beautifully. And as you can see in this case, you can see the increased presence of increased rouleau. This was a case of plasma cell neoplasm and was eventually diagnosed as presence of multiple myeloma. Of course, you can also pick up dysplastic nucleated cells in the peripheral blood, and which can also be picked up by the digital morphology analyzer. I'll switch the gears a little bit and take you through a few cases of WBCs wherein our digital morphology analyzer played a very beautiful role. So as I showed you previously as well, this is the facade or the page of the WBC, which you get in front of you when you go through the lab expert software of this instrument. And you are able to pick up your segmented neutrophils. Obviously, you can see that, all these neutrophils have been picked up beautifully and nicely stained, very beautiful color comparisons which are giving up, and you're getting very beautiful images in terms of the neutrophils which are having in front of you. And of course, the rest of the facade, if you look at the white blood cells, you're also able to pick up your giant platelets, large platelets, platelet clumps on the same page in this particular case in our instrument. And we are able to pick up, for instance, lymphocytes, monocytes, reactive lymphocytes, etc. And eventually even the artifacts are there. So all these are possible to be realigned also once we try to look at the morphology of these cells. So I'll show you this particular case. This was a 60-year-old diabetic lady who was semi-comatose, and wheeled into the emergency hours late in the night, about 11:30 in the night. And the issue was, what's the cause? But the moment we saw these digital morphology images, we know that we were dealing with something which was having significant toxic change, and there were these presence of Dole bodies in these neutrophils, and this vacuolation, which was obviously telling us that we're dealing with something which is a bacterial infection. She was immediately put on antibiotic therapy, and she became much better by the next day. I'm showing you two interesting cases right in front of you. One was a 42-year-old man who had turned vegan and was complaining of weakness, and this patient, we were able to pick up these cells, and obviously I don't think there will be any prizes for this. This is very obviously a hypersegmented neutrophil, the 6-lobe one and the 5-lobe one in this patient, which was picked up. And this was a case, who was having B12 and folate deficiency and was eventually found treated with B12 and folate and became better. There was another case which I mentioned, a 55-year-old man, a known case of rheumatoid arthritis, and was showing the absolute lymphocytosis. And when the cells were actually reviewed, this is the kind of cells we saw, where we had all these granules within the lymphoid cells. And we know we're dealing with a proliferation of, T large granular lymphocytes, which is a common finding in cases of rheumatoid arthritis. So this is another case, a case wherein obviously, as you can see, very beautifully, the blasts have been picked up. All these blasts have been picked up. There are about 72% of them. And they're all being picked up of various shapes and sizes. This turned out to be a case of acute lymphoblastic leukemia. And you can see the images of the blasts which were there at a relatively higher magnification. And this is relatively when we did improve the beta staining part of it in this particular case. Now, when we looked at the various cell lines, we tried to see whether it was correlated. What was correlating? When we look at the morphology, we want to see it under the microscope. And then we want to see whether the machine is giving us similar information from the instrument or not. And in this particular case, we tried to look at the counts which were obtained from the morphology or the manual microscopy against the digital morphology platform. And when you look at this passing by block regression analysis, you're seeing that there was a significant correlation between all the cell types between the automated or the digital morphology versus the manual morphology. And this obviously enhanced the sense of security in our minds to think that, yes, I'm not going to be missing out anything when I'm going to be using only digital morphology for analysis. Now, when we look at neutrophils, now we're trying to take cells individually. And if you look at the neutrophils here, again, the regression analysis curve shows an absolute correlation between the manual neutrophil counts versus the digital counting on the neutrophils on MCET hematology analyzer. The lymphocytes, again, there was a very significant correlation between the lymphocytes as well as the on the manual as well as on the digital platforms. And obviously, you're able to see that most of the counts, they were matching very beautifully. And almost similar stuff for the monocytes, except that in some of patients, we had a higher number as far as the monocytic counts were concerned. But then at the lower counts, we were able to differentiate between the two. And this variability obviously depends upon the human beings, and that's why there was significant variability there. Eosinophils, again, there was a significant correlation between the values which we got from the manual methodology versus the digital morphology. And of course, if you look at the blind Altman analysis plot also, there is some degree of negative bias in this particular case, but more or less, they correlate pretty well. When you look at the summary of all the statistics which you got for the WBCs for various cell types, what was very obvious, there was significant correlation for the neutrophils and the lymphocytes. And of course, for monocytes and eosinophils, also it was relatively significant. But for basophils, the numbers, just another case, we saw this case of a patient, who was ultimately proven to be a case of plasma cell neoplasm. And we found the presence of these plasma cells in the peripheral blood. There was also, this is the same case which I showed you earlier, wherein we had increased rular formation. And we were also having a very, very interesting case wherein the case was actually posted for bone marrow transplant as an aplastic anemia. And CBC was showing consistent pancytopenia, but there was this presence of these lymphoid cells, which are not fitting very classically into a typical lymphoid region, as you can, very classically see here. And when we did a more differential on the digital morphology analyzer, we were able to pick up these very classical hairy cells. And obviously, we absolved him the issue of going ahead with the bone marrow transplant. There's another part of digital morphology wherein you can use the immature myeloid cells or the IG fractions, which have been kind of vaguely being classified by different individuals, because we all have different thought processes with respect to what will form a myelocyte or a metamyelocyte or a promyelocyte. But when we look at the digital morphology platforms, they're able to give us a much better information with respect to this. And I know that we've been showing this in the previous presentation also, that we were able to pick up very distinct immature granulocytes, which were already flagged by the hematology analyzer parallelly. So what we are able to do with digital morphology platform is to actually get information which is useful for all of us. Just a few images of the abnormal lymphoid cells, some blasts, the lymphocytes, the granulocytes, whether the lymphocytes are there, whether the eosinophils, etc., they're all having different morphology. And this is something which we are able to appreciate from the hematology digital morphology analyzer. Now, let me go to the platelets. We all know that, platelet anisochromia is something which is at times very difficult to appreciate. And it's also sometimes very difficult to appreciate the internal complexity within the platelets and look at these granules when you're looking at usual morphological slides in your setups. And of course, I did tell you about the platelet satellitism, but this is something which has been picked up from the other analyzers, which we have had some work on previously. What is different on the platelet part of it for the MC80 is that we are able to get what we call the platelet on the platelet estimate mode. We not only have the automated pickup of the platelets, what they do themselves and give us an appropriate count with a V, but we can also do the manual count. Sometimes we are very interested to do a manual count on a smear. We can do the same thing on this particular instrument directly, from the digital morphology platform directly, and give us what is called the platelet estimate by a manual methodology. There is also a very interesting thing called the platelet pro mode for identification of platelet clumps. And this is because majority of the hematology digital morphology analyzers actually analyze data only in these areas. They just go to the central area and identify it there. But in this particular mode, they are able to identify the platelets on the edges of the cells as well. So platelet clump can be detected in the tails, edges, and the body. And again, we did a study comparing the platelet count by the hematology analyzer vis-a-vis those picked up by the MC80, and also the manual platelet count vis-a-vis the pro platelet counts, and we found a significant correlation with a value of almost more than 0.9. A few studies on the parasites part of it. If you look at the thing with, in fact, we were talking about the dengue illness previously, and my predecessor did talk about it. And we know that on a hematology analyzer, we are able to get this very classical, what is called the high fluorescence cells, and they correlate very significantly with the presence of dengue. At least that's what we have been proven. We have been able to prove in our center. And they all are comparable to what we call the reactive lymphocytes. In fact, I'm sure most of you would be aware of the fact that there are people who have presented data calling something as a pseudo-basophilia, and these would be nothing but reactive lymphocytes. And if you would see this, you will get a classical figure of 8 appearance on this scatter plot from the hematology analyzer. But when you look at the digital morphology, you're able to pick up these very characteristic plasmacytoid and lymphoplasmacytoid cells. This transition itself tells you, how the lymphocytes looked at when we were not having a very optimal staining to a day to day where we have been able to optimize the staining beautifully in our analyzer. Coming to the parasites, again, when we started, the analyzer was not really able to pick us the malarial parasite on its own till we tried to customize it and get it to our requirements and see how it is going to pick it up. In fact, if you notice in this particular case, in the large platelets, in the giant platelets, in the large platelets, and even in the artifacts, you are actually getting, these malarial parasites. And you can see all of them eventually when we've taken a closer picture of them. These are nothing but Schizon, the Plasmodium vivax. And this is another case, where we had loads and loads of parasite, as you can see in this case. Of course, it's given us the percentage of parasites, so at 10.7%, but this was only after we had reclassified a lot of them and picked it up very beautifully, not only in the WBC, the facade, but also in the RBC picture, where we were able to pick up beautifully all these parasitized red cells. There was another case where we picked up the presence of a falciparum, and you can beautifully see the presence of these, rings within the RBCs, and you can also see the gametocyte of the falciparum. And this again was very nicely and beautifully picked up by the hematology analyzer at the same time, wherein we were able to identify infected red blood cells, giving us the infected red cell percentages also. So in totality, if you look at this particular case also, you were able to pick up the cases not only from the hematology analyzer, but also from the digital morphology analyzer to give you the comprehensive diagnostics. Another case wherein we had a case of malaria once again, and in this particular case again you had these high fluorescent cells. There was always a question whether we're dealing with malaria or we're dealing with dengue or a combination of both. If you look at the eosinophilic part of it, you have this very characteristic appearance, and you also have an appearance here of the unlysed red blood cells which are there in this particular scatter plot. And when you looked at the data coming out from the digital morphology analyzer, just look at the beautiful pictures which have come up for the malarial parasite of various stages for a Plasmodium vivax in this particular case. So the digital morphology platform was not only able to pick up the information which we had already picked up from the hematology analyzer, but we were able to actually show it beautifully on the digital morphology and see that the parasites were beautifully picked up. And this would also help us to have appropriate quantification of the parasite index. So what was our experience so far on the MC80 that we've been having with us for the last about 1.5 to 2 months? I would say it was one that of learning. We learned a lot of stuff with respect to digital morphology as to how we are expected to set it up, how we are expected to have a good pre-analytics to make sure that the slide staining is optimal. Only then can we get the right information from the instrument. And if I may say, it is currently an ongoing activity at our center as we are maturing with the use of the instrument that we have. So just to show you, the best thing that I have been able to actually enjoy with the MC80 is the presence of both the morphology, the scatter plot data which is coming from the hematology analyzer, which includes the research use parametric data also, their eye flags also, and at the same time I can also get the morphology of the exactly same sample. If you see the sample ID here and here, it's exactly the same. And interestingly, all this is possible on this parallel left side, tray of the stuff where I can pick up. So if you want the data from the hematology analyzer, just click blood and you will get this data right on your screen. And if you want the data on the morphology, the same thing, you can just click on morphology and you will get the entire morphological data. So currently, if I look at it from my standpoint, I think the best part of this MCAT experience has been the Lab Expert client software, which allows me to look at both the things parallelly, which generally is not the case with majority of the other vendors which are there in the system. So to take home, what does it help you with? It helps you to standardize your approach to the morphology. It helps you to automate and optimize your lab for advanced workflow management in your laboratory. It can potentially help you to incorporate the image in your report. And sometimes, when you're sitting remote, you would like to get the images and see whether you're really dealing with the right, what kind of case are you dealing with. It obviously increases your efficiency. It helps you with the traceability of images, and you can also have cellular digital history of a patient. And obviously, when we are wanting to take an opinion from somebody who's an expert globally, the images can be transmitted across either on a cloud-based platform or through the virtual private network, or if nothing, but at least as a PDF format to somebody, a friend in need, who can give you an opinion. And obviously, we will be able to give a better turnaround time, and we should also be able to give better opinion to the patient for that particular case. Last but not the least, please remember, it's the man behind the machine who matters the most. We realized it very vividly when we were trying to standardize the entire process, and therefore standardization of staining, smearing, having the slide also, which should be appropriate. Sometimes you may have artifacts within the slide which can give you wrong information, and the machine will not be able to pick it up appropriately. And most importantly, making this whole thing work into a workflow for you to adapt and your colleagues to adapt is extremely important and mandatory before you really delve into the digital morphology platforms. Thank you very much for your kind attention, and I'm extremely grateful to my team, who've been handling this entire activity in our center to ensure that we're able to give good information across to our patients, and I'm able to share this information with you all today on this webinar. Thank you very much, and I'll be happy to take questions if there are any.
Thank you, Dr. Anil Handoo. Yeah, it's very comprehensive, and you share us a lot of case related to the digital morphology analyzer and related to the red blood cell, the anemia, white blood cell, and also some platelet case. And also you show us that the MC80 has a good for our, traceability, right? I think I am very appreciative to that. And because traceability of a report is also very crucial, especially in the nowadays, the situations of the patient and the hospital, some can protect ourselves when we have a traceables of the report. I think that is also very crucial. Thank you for your sharing. And let's see, is there any question from our audience? Let's check the chat box. And also, yeah, if you have the question, we can put in the Q&A box or the chat box also. Okay. I would like to share some highlight on the MC80 because we have the platelet promo, right? Just now, Dr. Anil and Daniel Endo have already shared. That is also crucial for we finding the abnormal platelet morphology, like in the edge or platelet aggregation in the edge of the smear or in the tail of the smear. That is also a good for finding abnormal of the platelet morphology. Let's check whether we have.
There's another question. I think it's by Dr. Ajay Shah, which is about, is the time for study manual smear and digital morphology for the patient, is it the same? Probably what Dr. Shah is looking at is, when we do digital morphology, does it take us more time to actually look at it, or takes lesser time to look at it? Well, the answer to that is, for me, it's a bit too early to actually answer you and say that, yes, it reduces my time to, review the smear. But what happens actually is, that because the instrument is actually aligned in such a way that it takes the information from the middleware and it's able to give us a smear without me intervening and saying, give me a smear now. So by that, actually, it helps us to reduce the time which we are otherwise going to take to make the smear. So that's where it gives us an advantage, number one. Number two, it also helps me to ensure that even when I'm sitting across, remotely, I can get the images and I can actually report basis that. And more importantly, when I don't even need to be inside the laboratory to look at it. So it gives me an added advantage there. So I am assuming at the moment, though we are still on the job to look at, does it really make an impact on our turnaround time? And hopefully we should be sharing that with you guys in our next webinar or next meetings whenever we meet. But for all practical purposes, my assumption is that it should definitely reduce the time of, actually reverting back on a patient's result. There's another question by Dr. Mamta, which says, if we run the bone marrow sample on the analyzer, then can we have the morphology? Now, the problem with the bone marrow samples is the bone marrow samples are having these bony spicules. They're also having fat in them. And, they have a possibility of clogging your analyzer's tubings. And that's why majority of the people would not want to run this, on the smear or on the sample. But having said that, if you filter your bone marrow sample through a 70 micron filter and then put it onto the analyzer, that will help you to get the slides on both the fronts and it should be able to give you the answer.
So let's see if there are any new question coming in.
So how many fields will it collect to see? Roughly about 100. Yes, you are right.
Well, yeah, we can set, yeah. As this, I would like to answer for Dr. Jay Shah. Yeah, we can set 100 cell to 500 cell based on your needed scan for the white blood cell. Yeah.
So generally, most of us prefer 100. We don't go to high 500 because the more the number of cells that you try to target, the more the time will be taken to review. So most of us set it at about 100.
Okay, I think that we have a very by far, yeah. We have a very, I think, interactive and Q&A section, and also we have a good presentation from our two prestigious speakers. And thanks for your sharing. I think that is very practical and it can help our audience a lot. From Dr. Andy, have a very, I think, very detailed characteristic of each of normal cell and share some case and help easy to understanding how morphology assists in the leukemia diagnosis. And Dr. Anil Handoo also show us how we can utilize digital morphology to helping us in our daily routine. Yes, and I think it will come to the end of this webinar, and we are doing a lot for this year. We have the initiative of doing the morphology education series from the beginning of this year. This is the episode 3. Yeah, just at the beginning I have mentioned. We would like to doing more for the educational platform to helping our younger scholarship or help our I think experienced speaker to share their experience in this industry. So now can you hand over this host to me, Dr. Anil? I think let me share my screen. Okay, yeah, I think it's okay. Now it's okay. Yeah. So now I think thank you all for staying with us for the 2-hour webinar, and we have a very good lesson from our two speakers, Dr. Andy and Dr. Anil Handoo. And we also have a good, I think, discussion. Yeah, I hope that we can continue with the next episode, and we are doing more such kinds of morphology webinar, or maybe in the future we can do some we can do some offline FDT. So I would also like you, if you want to share some your comments on this webinar, how do you grading of this webinar and what topic would you like to discuss in the next episode? And if we are doing the offline event, because I'm in charge of the Asia Pacific area, right? So which country would you prefer we will do that offline webinar? And input your comments and your suggestion. I would like to hear from you. Thank you all. Yeah. Bye bye and have a good day. Have a good night. Thank you. Bye bye.